This is Dr. Howard Strassler presenting the e-lecture Decision-Making in Restorative Interventions, Class V Cervical Restorations, and this Module D will look at the rationale for restoration replacement. Keep in mind the reason for restoration replacement many times is the same as for a Class I, Class II, Class III, or Class IV. So let's take a look. Restorative intervention for non-carious cervical lesions for Class Vs is dependent upon the size, more than 1 millimeter deep, more than 2 millimeters in height, as you see here on these two teeth, on the first premolar and on the maxillary canine. And these have been restored with a nanohybrid composite resin TPH3. There'll be times when we need a restorative intervention on non-carious cervical lesions where they're adjacent to existing amalgam restorations. And you can see these amalgam restorations on the first and second premolar are undercontoured. You can see the rotations on number 29. And these were restored with a microfill composite resin where the amalgams were removed and prepared. The root surfaces, the dentinal surfaces, were roughened with a round burr to create a uniform dent and smear layer for the adhesive procedure. The preventive aspect of treating Class V carious lesions, that besides a restoration replacement, we may do some type of enamel remineralization. Treating with fluorides, treating with amorphous calcium phosphate for remineralization. In fact, we may decide not to restore an area with caries because the caries is in the initial stages and it's remineralizable. The case where we're doing more invasive procedures where we see caries or defective restorations. And so these more invasive preparations are where we see the enamel demineralization with cavitation and our consideration towards composites or glass ionomers or in the non-aesthetic zone for amalgam. But throughout the treatment for anyone with Class V lesions, we're considering and continuing remineralization therapies. These are high-risk caries risk patients, and these cervical regions have demonstrated their risk. So let's look at the reasons for restoration replacement. And this is a review of something we've already covered. Secondary caries, recurrent caries, is the greatest reason why we replace composites, 26% of the time. Poor margins are also a very high reason, although one of the major reasons and the shift that's occurring currently is patients who are unhappy with the aesthetics, the unsightliness of a restoration, leading to greater replacement. But the tooth may fracture, the restoration may fracture. There are a number of reasons why you'd go in and replace an existing composite. Glass ionomers also are being replaced due to secondary caries. It may take an increased amount of time for those areas to become carious because of the fluoride release of these materials, but that these glass ionomers are still susceptible to poor margins and fracture due to pain and sensitivity, due to it being unaesthetic, as major reasons why recommendations are made to replace these restorations. So when we're replacing restorations composites, staining alone may not be an indicator. Ditching, gaps may not be an indicator, but in fact the clinical evidence to intervene on these teeth is the presence of frank caries. And in fact, on both of these restorations at the cervical margin, there's a gap and there's demineralization, there's caries forming at those marginal areas. In fact, when we take a look at sites in this research study without frank caries, only 38 out of 137 sites had softened carious dentin. Even in the presence of marginal ditching and marginal staining, those were not ways of predicting the presence of secondary caries around composites. That it was only the presence of frank caries, caries that's obvious that we can detect, as a reliable predictor of secondary caries. So let's look at where they're happening. Caries is more frequently seen at the cervical or interproximal margins than at incisal or occlusal margins, these high-risk areas. In fact, for the Class Vs, as we see here, we're going to see more recurrent caries around these composites, around glass ionomers. And that's not surprising. These areas became carious because they were at risk. Those risk areas will continue. So we're evaluating restorations as to whether they need to be replaced. We look at the contour. Are they over-contoured, under-contoured? What do the margins look like? Are they stained? Are they ditched? Are there fractures? Is there recurrent caries present? For composites, certainly the patient will point out and say, I don't like the way it looks. The diagnosis is UGLY, it's ugly, and we're going to replace it. We may see radiographic evidence of recurrent decay, of marginal failings. And in these images, we see some under-contoured Class V amalgam restorations that will treatment plan for replacement. If we take a look at the maxillary arch, you can see some non-carious cervical lesions on the two premolars. They're somewhat shallow. On the molar mesiobuccal root, it's a little bit deeper. No evidence of dental hypersensitivity. So we're replacing restorations due to over-contour or under-contour, due to recurrent decay. If we see marginal ditching greater than 0.5 millimeter, it's either carious or caries susceptible. We're replacing restorations due to overhanging margins and for marginal staining. Poor color match, generally patient diagnosed, is another reason to replace a composite restoration in a Class V region. And so if we think they're acceptable at this point, we're going to reevaluate. We're going to do active surveillance. We're going to note suspicious areas for reevaluation. But if they're defective, we consider complete replacement, whether it be amalgam, composite, or glass ionomer. We do consider some areas for repair if we know the history of the restoration, we placed it. That it's only one isolated area, we can go in and just do a repair of the bad margin. We may decide to extend preparations to areas that we should have extended in the first place in order to in fact make the restoration more preventive. Even though one could say, but they're not minimally invasive, they're not conservative, we're extending it, we're looking at past dental history and how disease has proceeded for that patient. So we take a look at these defective Class Vs. There's marginal discoloration and marginal gaps. In fact, where these poor margins are, I can see frank caries, and I can detect frank caries. I see color mismatch that's present. And in fact, when you look at all the surfaces and Class Vs, you can see this patient has significant caries risk. And without their participation in taking care of their own mouth, the filling of these teeth, the restoration of these teeth, is only a very, very temporary measure. These teeth in the future will need root canal therapy if the patient wants to maintain them, post-incurs, and in all likelihood crowns. Or around these defective Class V amalgam restorations where I have root softening on these cervical areas of 3 of the lower incisors. It's soft and sticky. We can see that during the placement some of the amalgam must have fallen into bleeding gingiva because we can see amalgam tattoos around these restorations. Or we see marginal staining. Now you might say, is that marginal staining or is that recurrent decay around that maxillary canine? That looks very severe. This root surface is hard and shiny. But other composites are demonstrating some staining, but whether or not it's carious. And in this situation, we decided to investigate this composite to see if this marginal staining that's superficial and underneath the restoration has led to caries. And so we very carefully remove the composite, removing the enamel adhesion and popping it out. And in fact, when we go in and remove it and pop out the restoration, in fact, the tooth shows no level of staining at all. It shows no evidence of caries. In fact, you can see in the lower right-hand corner, there's the restoration removed, and you can see the stain had permeated on the inner surface of the composite. This restoration was obviously placed with very poor adhesion, adhesive techniques during its placement. Or the patient we saw in a previous module with radiation caries. And they not only have initial caries, they also have recurrent decay adjacent to many existing restorations. And it will be a battle to keep this patient restored and to follow up treatment. We'll probably give the patient trays to have and wear with fluorides, prescription strength fluoride. This patient will need frequent recall. And at this point, the idea of extracting teeth may not be a good plan with the fact that they've had head and neck radiation. Or the case where the tooth is covered with calculus and it's impossible to make a diagnosis as to whether or not the teeth need restoration until in fact they're clean. We'll sometimes see areas of non-carious cervical lesions that form carious lesions, as we see in the facial of this first premolar. There are no lesions on the adjacent tooth. This tooth happens to have a significant wear facet and fremitus, which probably contributed to the non-carious cervical lesion, the abfraction that was there. In fact, by history, that tooth may have had a previous restoration that had leakage under it that formed that carious area, but the patient isn't a good historian for that, but that's something to ask. Where we see the same thing on number 5 and 6, and in this case we know that number 6 had a facial composite that wasn't retained. And the occlusal forces and the flexing on the root of the abfraction lesion are why these composites are hard to retain. The composite on number 5 had leakage, and hence we see this carious lesion. And when we're choosing restorative materials, we've talked about for the patient with xerostomia with dry mouth, the high carious rate, and using glass ionomers with their fluoride release. But what if the tooth is going to be clasped with a partial denture? In fact, that tooth is going to have the retention for the partial on the class 5 region that's going to be restored. Or the patient who has heavy occlusal function and abfraction, what restorative material are we going to select? Well, the patient with xerostomia, we're considering glass ionomer and amalgam as choices for restorative. In fact, in non-aesthetic zones, amalgam is a more longer-lasting restoration than glass ionomer. In fact, the xerostomia, the dry mouth, seems to have a negative impact upon the glass ionomer. The glass ionomer does better in a more normal, moist environment. The amalgam does a better seal in these areas. Or the considerations to restore, we're going to place a class 5 on a tooth that already has an existing clasp for a partial denture. And in fact, the choice for restorative material for areas where the partial denture will be applied as a clasping area, as a rest area, would either be amalgam or composite resin, and not glass ionomer. Heavy function on teeth causing an abfraction, as we see in this mandibular first premolar, that's going to be getting a clasp as part of the partial. That we might consider placing a retentive groove at the gingival wall to give us additional retention to the flexing forces to retain that composite. Consideration when the patient isn't wearing their partial denture to fabricate an occlusal guard for them, an occlusal appliance, to help control the parafunctional occlusal habit. And we saw these undercontoured Class V restorations combined with the fact that we have a non-carious cervical lesion. Even though this premolar is rotated nearly 90 degrees, the fact it's at the cervical third and it's on what is now anatomically the facial surface by position, even though it's not the facial surface of the tooth by its dental anatomy, it's still considered a Class V. You've been listening to and watching the e-lecture, Decision Making and Restorative Interventions, looking at rationale for restoration replacement. It's the same for all restorative materials when we make the decision based upon recurrent caries, marginal gaps, fracture of tooth, fracture of restoration, lack of aesthetics. All reasons why we would go in and replace an existing restoration.